Professor Dietz will talk about the study Does the Epino Prevent Pelvic Floor Trauma? It's a multi-center randomized control trial.
Thank you. This is very much a team effort. It's dragged on over a period of 6 or 7 years. And I've really only been the supervisor, so it's embarrassing for me to speak here. I've tried to get others to do the talk for me, but I couldn't talk them into it. It might have been easier in other circumstances. Now, the rationale for doing this trial was that we now know that maternal birth trauma in childbirth is common. 10 to 30% suffer avulsion of the levator ani, and another 10 to 20% suffer oasis, that is trauma to the external and the internal anal sphincter. And what that means is that maternal birth trauma is a lot more common than is generally assumed. And both those conditions, both oasis and avulsion, are clearly associated with future morbidity. Hence, prevention of such trauma seems highly desirable. And when we started looking at this, there was a device freely available on the market in Europe and in Australia that is supposed to stretch the birth canal, which from my point of view was quite likely to result in a reduction of trauma. That's what the device looks like. It's basically a little bit like a periodometer with a balloon at the business end. And women are supposed to insert this balloon device in an empty state, as it is on the screen there, from 37 weeks onwards, at least twice a day, blow it up until it gets uncomfortable, and then slowly pull it out. And our research midwife, who was running this study for the entire duration, tells me that a substantial minority of women actually got to 8 or 9 centimeters. So it works for dilating the perineum, that's for sure. But we were interested in something quite different. Our null hypothesis was antepartum use of the Epino device does not prevent levator trauma, and we tried to disprove that null hypothesis. It was a multi-center RCT, July 07 to March 14. The inclusion criteria were an uncomplicated singleton pregnancy between 33 and 36 weeks, because the patients were supposed to start using the device at 37, a maternal age equal to or greater than 18 years, no previous pregnancy beyond 20 weeks, and with the patient aiming for a normal delivery. So of course we did not include somebody with a breech baby who was aiming for an elective cesarean. We used a computer-generated randomization list. The sample size of 660 was based on power calculations, which we had obtained after doing a pilot study that had randomized 200 women, and we had follow-up on 134. The primary outcome was levator avulsion, and many of you would have heard me talk about this before. There's, in a substantial minority of women in childbirth, the puborectalis component of the levator gets disconnected from the sidewall. It gets torn off. And the prevalence of that is somewhere between 10 and 30%, depending on obstetric practice. And these images, if I could have a pointer, a bit far away, isn't it? These images here show a normal muscle. So the connection, this is the symphysis pubis, the inferior pubic rami, left and right, and that's the muscle connected to the bone here and there. Connected here, connected there, connected here, connected there. The most important finding on this side is that in the central slices, but also further up here, this is the patient's left-hand side, which is still normal. The right-hand side is completely disrupted. There is no connection anymore between the muscle and the sidewall. That constitutes a complete right-sided avulsion because we're looking at the bottom from below. A secondary outcome was hiatal over distension. And what you can see here is a view in the mid-sagittal plane on Valsalva, where the symphysis pubis, the bladder, the uterus, and the anal rectum. And this is the view in the axial plane, which means, again, you're looking at the bottom from below, and this is the levator hiatus, the symphysis here, the pubic rami, the puborectalis component of the levator, the anal rectum, the vagina, and up there the bladder. So in this lady, there's the hiatus is substantially increased. The definition of hiatal over distension was an increase of 20% or more compared to antenatal values in women who did not have a full avulsion. Another secondary outcome was obstetric anal sphincter injury. We determined that by imaging because the clinical diagnosis of oasis is subject to very marked detection artifact. The vast majority of oases are not discovered in labor ward in my unit or in my world. And what we do there is, this is the anal canal in the mid-sagittal, and we slice the entire EAS from top to bottom. This is below the EAS, this is at the subcutaneous level of the sphincter. So you can see a dark ring here. A dark ring here, that's the internal sphincter. And you see, that's not going to work. And you see a bright ring here, which is the external sphincter. Over there, you can see that this donut shape is disrupted both for the internal sphincter and for the external. There's a gap here. That's what happened. In the end, we did randomize 660 women, and there were a few more in the Epino group. There's the reasons here for loss on follow-up, and in the end, we had 266 in the intervention arm and 233 in the non-intervention arm for assessment. These are the results. 504 returns, and follow-up on average at 5.1 months. The frequency of use, on average 16 women used this device on average 16 times, and some used it up to 60 times. These are the prevalences for the main outcome measures of avulsion, 12.8, hiatal overdistension, 12, and significant anal sphincter defects, 18.1. That's a comparison of the control group and the Epino group for obstetric parameters. That is what we managed to obtain from our obstetric database. That's why it's still 660, and it's enough to say there's no difference for anything at all, which is really rather disappointing. Now, on imaging, when it comes to the primary, to the main outcome measures that I've presented to you before, the numbers are lower because of loss to follow-up. So there's 233 in the control group, 266 in the Epino group, and you can see, again, there's basically no difference. If there's any difference at all, then there is a slight increase in sonographically detected sphincter trauma in the intervention arm. We've done this as a treatment received analysis as well because of significant crossover, and you can say it's pretty much exactly the same. In conclusion, we have found no evidence for a protective effect of the antenatal use of the Epino device on pelvic floor structures in primipray. There may be a marginal negative effect of the Epino use on significant EAS defects, but frankly, with all the analysis we've done, if we did a Bonferroni correction, of course, that would disappear. So I'm quite prepared to consider this spurious. And I have no affiliations to disclose. Thank you.
Thank you very much. This paper is open for discussion. Can I ask you a question?
Yeah, sure.
We have the Epino also in the Netherlands. How did you get all these women motivated to use it?
Well, it took a while to recruit. But in actual fact, at the inner city hospital, that is one of the two sites, there was rather strong support from birth center midwives because they believed in it. And you may be aware that in midwifery, there's, as regards the Epino, there's very much two camps. There's one camp that very much believes in it and wants people to use it and of course would support such a study. And basically at one hospital, they were self-recruiting. We didn't have to do a thing. People came to us. And there's another group, more prevalent at my hospital, who think that dilating the birth canal may actually do damage. That is, may over-distend tissues. And we've tested that. That doesn't happen. Either way, it doesn't really matter, because if it's no good, then we don't need to discuss potential negative effects.
Okay.
Yes?
Peter, thank you very much. How did you come up with the prescribed frequency of use? And apart from asking, did you use any other fidelity measures?
Yeah, this is very much a pragmatic trial. And that means we use the manufacturer's instructions. In essence, the only advice that we gave people was to explain the manufacturer's instructions.
And the fidelity monitoring was just asking
Sorry?
To monitor the fidelity to your intervention.
You mean the uptake? You mean the uptake?
Yeah.
Yeah. Well, you saw we monitored mean use, that is the incidence of use, and we also monitored maximum distension reached.
And was that by self-report? Because I'm reliably informed by a colleague that at 37 weeks,
I'm not sure
you're lucky
how
to
else,
get down there.
I'm not sure how else you would do that. Ask the husband? I don't know.
I have one other question. If
Yep.
I was a bit surprised about the results about the anal sphincter.
Me too.
Do you have some hypothesis on that? Are they stretching the wrong part?
Does it matter?
Well, if you get more sphincter
No.
trouble.
What I'm trying to say is that, after all, the only potential motivation for using the device would be if somebody could actually show a significant benefit. And this is not an underpowered study. I mean, 660 women, that's quite a decent size. So I cannot possibly imagine that any significant positive effect would be hiding behind our data. And if that's not the case, then we don't really have to worry about adverse effects because there's no reason for using it in the first place.
Okay. Beth Shelley, United States. I'm intrigued by your point that people were self-referring. And so you have a group of very motivated people and potentially very informed people
Yes.
who then you're going to randomize. And so there's a group of people that don't get this device. Do you think that maybe some of them would have been self-stretching?
Yep.
And was
Yep.
that controlled for or asked for or any?
This is why, if you think back to the results slides, the treatment received analysis has quite different numbers from the intention to treat because of crossover. I mean, we can't possibly stop people from buying a device if they end up in the non-intervention arm. And we put great emphasis on that being okay so that it would not be hidden from us. So I'm pretty sure that people actually told us the truth. But then, of course, the point you made before, if you want to put it this way, the recruitment artifact, that applies to all prospective research. It applies to the prolonged study just as much. Well, of course, those women were more motivated. They were, the longer you deal with a group of patients, the longer you establish a relationship with them, of course, you mess up everything. But there's the Heisenberg principle. We can't do anything about that.
Thank you.
Okay, thank you. If there are more questions, thank you very much.
Thank you.